Thank you for having me speak today. I recognize a lot of people out there. Rabbi Greenstein was one of my miracles, and I just want to set the record straight. I didn't think he could do it because I didn't know he had a wife that would make him do it. That was why, because this not so small man at the time, who I could tell liked his steak and his Danish and everything else on top of it, was never going to go on this diet without the support he was going to get from his family and his wife. And I looked at his wife and I said, there is a solution. It may work and it may not work. I don't know, but it's going to be a lot harder than taking medication. It's going to require a very important and motivated person to do this, because it's not that simple. And the reason he was the perfect person for the diet was because it not only addressed his inflammatory bowel disease or his Crohn's disease, but it addressed all of his medical problems. And I said, if you do this diet and it works, you will feel better not only from your Crohn's disease, but from your blood pressure, your cardiac issues, your anemia, everything, your diabetes, everything will get better. When he came back to the office 3 months later and had this smile, and I put him on the scale, you don't know the joy that we had. And he was down from 19 to we would count this many medicine, that many medicine. Every time he came in, he was coming off medication, and it worked for him, and it worked very well, and it was great. And sometimes I might be abrasive to get somebody motivated, and it's remarkable. So I'm one of the few doctors that I know of who has belief in SCD diet for treating inflammatory bowel disease, more Crohn's disease, and ulcerative colitis. And I'm just going to give you, unfortunately, some science, because I think that's why I'm here. I don't have the knowledge of the Torah. So many of you heard my lecture from a few years ago, and some of it is going to be repeated. But inflammatory bowel disease is a condition that constitutes both Crohn's disease and ulcerative colitis. They are very similar conditions that affect the bowel or the intestine. They're very similar, but they are not identical. So ulcerative colitis is very easy to understand because that's inflammation just in the lining of the large intestine or the colon. And when we talk about inflammation, I just tell people to just think of it as there is a burn in the intestine, and that burn can be superficial, just a little bit or a lot, and it can affect a small degree or it can affect a large degree of the bowel. And depending on how much of the intestine is burned and what the degree of the burn is or what the degree of the inflammation is, you will then have symptoms of ulcerative colitis, and typically it's diarrhea and bleeding. Crohn's disease can be very similar, but it's not always. Usually Crohn's disease is an inflammation or burn involving not only it involves both the small and large intestine, so the colon and the small intestine, and typically it affects the right side of the bowel, which is where the end of the small intestine or the ileum is, and then the colon in some degree. And that is more classic for Crohn's disease, and Crohn's disease, the presentation is very different, because many people have Crohn's disease for many, many years and don't even know they have it, because they don't necessarily have diarrhea, they don't necessarily have pain, they don't necessarily have bleeding, and then all of a sudden one day they find that they're anemic, or they're a child that doesn't grow or doesn't go through puberty, or they develop something called an abscess or a fistula around their bottom or their anus, or they find out that they're anemic, or one day all of a sudden they have a blockage, an obstruction. So Crohn's disease can present very differently than ulcerative colitis, even though they are variations of probably a very similar genetic predisposition. So the cause of Crohn's disease and ulcerative colitis is unknown, but we believe that there is a genetically susceptible host. It is much more common in the Jewish population, the Ashkenazi Jewish population, but we see it in all populations, but it is much more common in this population. We tend not to see it in third world countries, Africa, some areas around the equator. We tend not to see it in the tropics. So we believe that not only is there genetics, because when these people move to America or Europe, we believe that diet plays a role. So somehow the genetics with some environmental factors such as diet, maybe pollution, maybe plastics that we use, but there's an environmental thing that happens. I tend to think it's more dietary, but there's not 100% data. And then that interaction with your intestine, with your intestinal bacteria, your microbiome. It is the interplay of your genes, your environment, and your microbiome, because we know if we take experimental models of Crohn's and colitis and we get rid of the microbiome, you don't get inflammatory bowel disease. So you need to have an intact microbiome. And we are learning more and more about the microbiome as studies go on. 10 years ago, the microbiome is not the same as it is now. Now we know that the genetic makeup of your microbiome is much more than the genetic makeup of you as an individual. In other words, the genes that constitute the trillions of bacteria that live in you have more genetic data than you as an individual in your intestine. So something about the microbiome, we believe, interacting with the genes and the environmental factors then interplay and give people inflammatory bowel disease. What's interesting about inflammatory bowel disease, when you say, well, what do you mean the gene? What gene is it, Dr. George? Well, it's not one gene. It's probably many, many genes. And I know that many of you have been contacted or have heard information about genetic studies that we're doing at Mount Sinai to understand and to better understand the genes, because a lot of this stuff is dynamic, because as we learn more and more about how to study genes and how to study the microbiome, we're going to find out more information. So many of you have been or will be contacted for your genes, because we want your genes, and then one day I'm going to want your stool. As crazy as that sounds, because we want to figure this out. We want to figure this out because this condition can be very, very disheartening for some patients. But I will tell you that Crohn's and ulcerative colitis is a condition that we can treat. And there are many different treatments. So President Eisenhower had Crohn's disease, okay? There were people playing in the National Football League. I'm not sure that many of you are watching the National Football League, but these are world-class athletes that suffer from inflammatory bowel disease. So they are living, they are having children, they are working, they are studying, they are completely functional. So it is a condition or disease that we can control. Unfortunately, we don't know of a cure. It's not like having strep throat where you take penicillin and the strep throat is gone. It's a condition. Like diabetes is a condition, hypertension is a condition, but we can certainly manage it. Diet is one way, but there are other things that we need to do to manage this condition. And I just want to emphasize that everybody's Crohn's and everybody's ulcerative colitis is different. So what might work for somebody might not work for somebody else. It's not, oh, I have this, so I'm going to do what my neighbor did, and if I do exactly what my neighbor did, I'm going to be better because it worked for him or it worked for her. That's not the case in inflammatory bowel disease. Sometimes it works, and sometimes it doesn't. And what we are recognizing in medicine is that we need to take a personalized approach to each person. Each person's case is different. You're diagnosed at a different age. You have different medical conditions. You have different social needs. You have different disease states. It's very different. Your social network, your stress, everything is different in each person, and you have to tease that out when the person's sitting in front of you. Even if he is a very large man who I didn't think was willing to go on a diet, but he did. I mean, he is a champion. He is a champion. I really have to thank Miss Weiss. I know it's the middle of the lecture, but she educated me. Okay, because when I started in medicine many, many years ago, when we go to medical school, if there's a 4-minute lecture about nutrition and diet and, 20,000 hours of medication, I think that's an understatement. When I was a fellow at Mount Sinai, meaning I was learning about gastroenterology, and I was learning about Crohn's disease in 1992, we would say, oh, those people are on some diet, just forget it. And that's what I said, okay, forget it, all right? I forgot it. But there were patients who would come to see me, and I would say, well, how you must be taking the medication, you must be doing fantastically, and they would smile. I would say, oh, good. And then they'd say, well, I'm really not taking the medicine. I said, yeah, but you gained 20 pounds, your blood tests are better, and your energy, you look good, you know what? And then they would tell me they did the diet. And then, I'm not a nutritionist, and I'm not kosher, and I'm Greek, you may know or may not know. So there's a lot of things that I didn't understand about kosher, SCD, some of the traditions that you have. But what I did understand was that it was time for me to learn. And I'm not going to pretend to be a nutritionist. So Ms. Weiss has been a very valuable resource in terms of working together with her and with her network to help people and guide them through the diet. And over time,
these are some questions.
oh, well, yeah, we'll do that. Over time, we really have come to, I think I met her twice. And somehow we have this relationship, this working relationship that goes unspoken. She knows what I need, and I know what she needs. And we know what the patients, and it's all about the patients. It's not about our needs, but we work together to try to make everybody healthy. And I'm going to stress, not everybody gets better with medication, not everybody gets better with diet. Everybody needs different care, and you have to figure that out. It's no good? It says right in front of my mouth. Okay. All right. So, and the other thing we're finding out lately is stress management. Because we used to think that stress caused Crohn's disease, or stress caused colitis, or stress caused this, or stress where the person was stressed because, but you know what? What we found out, and finally there are studies to prove it, is that probably the most important factor, not in causing Crohn's or colitis, but in instigating an attack, is stress. Stress really affects the body in ways that we don't understand, but it promotes an exacerbation of the underlying inflammatory bowel disease. So we work together with diet, medication, stress reduction or stress management, exercise, yes, believe it or not, exercise, and trying to maintain health overall, health in general, more holistic approach, things that I never talked about in medical school where I went. A more holistic approach to the patient to make them feel better. And exercise does not mean going to the gym. Exercise means being physically active, walking, not sitting around, but being physically active and getting your body moving, because that will help you. So I can't talk about treatment of inflammatory bowel disease without talking about medication and surgery. Okay? So probably the two people most responsible for my learning about inflammatory bowel disease are David Sacker and Dan Present, who are both professors at Mount Sinai, both of whom have now subsequently retired, and Henry Janowitz, and my partner, Asher Kornbluth. But Sacker and Present taught me the most. But one thing they taught me was that surgery is not a failure. It is a different therapy. So who needs surgery? People need surgery if they have cancer. So some people, unfortunately, develop tumors from their inflammatory bowel disease, and they absolutely need surgery because you've got to fix that. People who are hemorrhaging absolutely need surgery if they're hemorrhaging very briskly and need to have an operation. People with perforation, which means that there's a hole in the intestine, you can't just fix that without an operation. That needs to be fixed, or the person will be very sick. People with along the lines of perforation who have toxicity, in other words, the intestines are so inflamed that their body is shutting down because of infection and toxicity, they require surgery. And then there are people who have what we call abscesses. Sometimes they can get away with little surgeries, depending on where the abscesses is. And then what we call the relative indications for surgery are people who have failed all other treatments. Well, let's say you did the diet, you did the Remicade, you did the 6-MP, you did the methotrexate, you did all these things, and you're just not getting better. Well, sometimes an operation will make you feel much, much better, and then we can go on from there. People with blockages, obstructions, repeated blockage, what happens in Crohn's disease over time is you develop scar tissue, and the scar tissue closes the intestine down to where nothing gets through. Well, a lot of those people will benefit greatly from an operation to fix that blockage. And then we can decide what to do after to make them feel better and gain their strength. But if they can't get any nutrition in because they're blocked, many of them need an operation. That's where I'm going. So we have very good surgeons who can help you. And then you discuss what is the surgery, because there are different surgical options for different conditions. Medication. Okay, so there are two goals of medical therapy, or medication and medical therapy. Actually, this holds for diet and for my medicine, which I still use. I'm always hoarse. Yeah, this is, I'll have the water, but with or without the water, it's the same. See? So the goals of medication are to improve how you feel. Am I going to feel better if I take this medication? And then the other goal of medication is to prevent the natural progression of inflammatory bowel disease, because unfortunately it's not being cured, but we put it into remission. And what does that mean? Well, if you take a look at patients with Crohn's disease and you look at the natural history of Crohn's disease, between half and 2/3 of patients with inflammation in the ileum and colon in that segment on the right side will require one surgery in their lifetime because of blockage, infection, infection, abscess, toxicity. So more than half patients require one operation, and that time period is typically 7 to 10 years after the diagnosis. And of half the people who have one surgery, they will require a second surgery. So the new thinking in inflammatory bowel disease is not just to make the patient feel better, but to prevent them from having complications and repeated surgeries in the future. So how do I approach it? Well, what does Dr. George do? Well, when I look at a patient with inflammatory bowel disease, I think to myself, if I do nothing for this patient, what's the worst thing that can happen? What's the worst outcome? And then if I do something, what's the best outcome? And then what's in the middle? So if I take patients with inflammatory bowel disease who have a very, very long segment of inflammation, and my concern is if I don't treat this long segment of inflammation, what's going to happen? Well, if they need surgery and that's the final outcome is that a good outcome? I mean, do I want somebody, let's say, with 3 or 4 feet of inflammation to have an operation? To me, that person, I'm more aggressive. I tend to be a little more aggressive with. I tend to try to give them medications, my medications. If a patient has a short segment of inflammatory bowel disease, where I say, okay, if I don't do anything, what's the worst possible outcome? If the worst possible outcome is 5, 8, 7 years from now, they require 3 or 4 inches of their intestine removed, I say to myself, well, do I want to take drugs for 4 inches of my intestine being removed in 10 years? I said, probably not, if I don't have to. And then there's everybody else in between. So the medications that we use, and again, they're different for ulcerative colitis and Crohn's disease, and you've heard of most of them, but mesalamine, which is the Lialda, Azocol, azulfidines of the world, those tend to be more beneficial in ulcerative colitis than in Crohn's disease, and they tend to have very few side effects and be very well tolerated. And in ulcerative colitis, they actually tend to work very well in enough patients, and they tend to keep you in remission. And to me, mesalamine, if it works, has very few side effects, and it's easy enough to take, and because the benefit is there and the risk is so low, I tend to use those medicines with ulcerative colitis more frequently. They tend not to be that effective in Crohn's disease only because of the location and depth of inflammation in Crohn's disease. Steroids I try not to use too frequently because they have potential side effects, short and long term, but if somebody is very sick and you need to get them better very quickly, we can use short-term steroids to make them better quickly, but we tend not to use them in the long term if we can avoid it. Then we get to the fancy medicines, the medicines that are injected, or the medicines that are taken orally that suppress the immune system. So you just have to realize that in 1999, I wrote a paper on the use of 6-MP in ulcerative colitis. So I do use these medicines. There are some people who do not get better with the mildest medications, and that's in ulcerative colitis, and that's probably between a third and a half the patients who just don't get better. And you need to make them better, or they keep requiring steroids. So 6-MP is a medication which is a tablet people take that suppresses the immune system by lowering the number of a particular type of white blood cell. And the reason I tend to favor that medication is because it's easy to take, it's inexpensive, it's not an injection. We've been using it since the 1970s. And if you tolerate it and it works, it tends to work very well for long periods of time. Do people get side effects of the 6-MP? Yes, they do. And in those patients, we can't use it. Can people get infections with 6-MP? Yes. And in those cases, sometimes we have to stop it. Do people need to be monitored on 6-MP? Absolutely. I monitor them, I follow them closely, And in patients in whom it works very well, and we can use it for prolonged periods of time. Methotrexate is an injection that acts similar to 6-MP, which I tend to use very, very, very infrequently. Methotrexate I also use infrequently because women cannot get pregnant with methotrexate. 6-MP you can. Dr. George, can I get pregnant with 6-MP? Yes, you can. Dr. George, can I get pregnant with? Yes, you can. The answer is yes. Okay. Then we have the biologic agents, which are the fanciest, most expensive, and potentially, in some instances, the ones that have most potential side effects. And those are the one category is called anti-TNF drugs. So that's Remicade, Humira, and Cimzia. These medications block a protein that the white blood cells secrete when they're activated. So whenever you have inflammation being promoted, you make this protein called TNF, tumor necrosis factor. It's the same thing that makes you feel lousy when you have the flu. You have too much TNF. It's the same thing that gives people rheumatoid arthritis. It's the same people that gives people psoriasis. It is this protein that promotes inflammation. So if I block TNF, it will make some patients' inflammation go away remarkably well. And in some cases, you can't even tell they had inflammatory bowel disease. So, Dr. George, that's great. And I say, yeah, I know. But does it work in everybody? No. It probably works in between 40 and 60% of patients, maybe 70. But the problem is that in half the patients who take 6-MP, take Remicade or Humira or Cimzia, these anti-TNF drugs, there's a dropout over time. Less and less people take them because of side effects or because they stop working because their body rejects the medicine. One way to prevent that from happening is to use what we call combination. You use 6-MP with Remicade, 6-MP with Humira, 6-MP with Cimzia. And that lowers the possibility of this condition from happening where you stop getting better with the medicine, where it wears out. And then the patients say to me, but Dr. George, now I have to take 2 drugs that suppress my immune system. I know. So now I'm more likely to get an infection. I know. Now I'm more likely to get a potential thing called lymphoma, which is a cancer of my lymph nodes. I know. I get it. I don't always use them, but sometimes I have to use them. So the one medicine that I want to really focus on today that is out there that is new is called Entyvio. What is Entyvio? I am not the scientist who figured this out, and I'm not going to pretend to be the scientist that figured this out, but this is a very novel medication that, believe it or not, skirts the side effect issue. Really? Yes. So how does Entyvio work? So your blood vessels carry blood throughout the entire body, including to your intestines. So your blood vessel is like a hose. The blood cells go through this hose and go throughout your entire body. The blood vessels that are closest to the wall of this hose, instead of shooting, they roll like a ball or a snowball will roll. It rolls up against the lining of the hose. And when your intestines become activated with ulcerative colitis or Crohn's disease, you make these little fingers on the wall. They're not fingers, but that's what I'm going to call them. These little finger-like projections which grab the white blood cells and pull them into the intestine. Somebody a lot smarter than I am figured out how to block that pulling of this white blood cells out of the bloodstream and into the intestine. And that is called Entyvio. But the novel thing about Entyvio is that it does it in the intestine. Doesn't do it in the brain like Tysabri. It doesn't do it in the heart. It doesn't do it in the kidneys. It doesn't do it anywhere else in your body. So when you look at the studies, and there are studies that we have for about 4 or 5 years now, and I have patients who were in the studies, we don't talk about immune suppression. We don't talk about lymphoma. We don't talk about any of these things to our patients because those things don't happen with this novel medication. Does it work in everybody? No. If it worked in everybody, everybody would get it. So it probably works like every other medication in somewhere between 40 and 60% of patients. So it all depends. So then we get to diet. Does diet work? Yes. It works. Period. No questions. Does it work in everybody? No. Does anything work in everybody? No. I wouldn't have a job. So diet works. So why do I think diet works? Well, if you look at pediatric patients, pediatric studies in Crohn's disease, and you give young children or infants what we call an elemental diet, which means completely digested food, food without anything the body has to do. So it's amino acids and proteins that are completely digested, that immediately get absorbed, where the body has to do no work. And you give patients an elemental diet, and you compare them to patients who get prednisone, the same amount get better, if not more, on an elemental diet. If you take patients with Crohn's disease and you don't feed them, because I know you Crohn's disease patients, when you're sick, you stop eating and you feel better. The inflammation goes away. So that is some science as to why diet, does diet work? Yes. So, Elaine Gottschall's daughter had celiac disease and ulcerative colitis. They put her on a gluten-free diet, and then they put her on this SCD diet, and not only did the celiac disease get better, she had ulcerative colitis, the colitis got better. So the question is why? Why do they get better? And the answer is, we don't know. We're trying to figure this out. We believe that by starving the microbiome, your intestinal flora, of sugar, of certain sugars, you will be able to modify the microbiome so that you have good bacteria and not bad bacteria. And that by doing this modification with the SCD diet, that is what alters the immune system, so that your immune system, instead of fighting your intestine, allows your intestine to heal, because that interplay between the microbiome and your immunity has now become favorable instead of destructive. So that is the theory, but how do I don't know if just by altering your diet, you've done nothing to your microbiome, but you've changed your immune system, even without altering the microbiome. Or how do I know what the microbiome is? Like if it's the microbiome, why don't I just give you bacteria? Just give you good bacteria. Just give you probiotics. Take these probiotics and everybody will get better. Because that doesn't work. Maybe we're not giving you enough probiotics. I don't know. So maybe instead of going on a diet, which stay on the diet, maybe instead of going on a diet, you just eat good bacteria, and then you don't have to be on a diet. You can just eat good bacteria. So we don't know the answer to that. So as Ms. Weiss knows, I'm going to plug this one more time. We wrote a 12-page protocol, including the doctors at Mount Sinai, who are finally starting to agree that the diet helps, to address these questions. We're going to put people on the diet. We're going to measure their microbiome. We're going to measure their immunity, and we're going to see what happens. Number one, do they get better? What percentage of them get better? And then can we figure out why they get better? Unfortunately, these studies cost a lot of money, and drug companies, pharma, they don't want to pay for these because it's not a drug. I'm not giving you a drug, I'm just giving you a diet. So pharma doesn't want to pay for the study. So if anybody has $450,000 laying around and they want to sponsor this study, which is going to answer these questions, that would be great. So the one question that Ms. Weiss and I have been wrestling and trying to tackle with the diet is the same question that we have with medication. How long? How long do I take the medicine? How long do I have to be on the diet? So until we figure out the cure or the absolute cause of inflammatory bowel disease, the answer is still not that clear. So I will clear up some of it. I'll clear up what we know about medication. Some of you are going to be happy with this, and some of you are not going to be happy with this. So with medication, with 6-MP for ulcerative colitis, which was the paper I wrote, if you needed 6-MP to get your ulcerative colitis better, not if the doctor just gave you 6-MP. Most of us don't do that, by the way. But if you needed 6-MP to get your ulcerative colitis better and you went into remission with the 6-MP, if you stop it, 90% flare up. I know that's not good. Nobody likes that answer. Why? Because when you stop it, your immune system goes back to the way it was, okay? And it takes a year for that to happen. So many people who take 6-MP stop it and say, oh, I missed it, I feel great, nothing happened to me. Then they wait another day, they don't take it again, oh, I still feel good, there's nothing wrong with me, I don't have to take the medicine. And I say, I'll see you in a year. And then a year later, because now they've got to get the white cells activated again, then the white cells have to interact with your immune system in their gut, and then the cascade begins, where they start to feel sick. Because we haven't done anything to change the underlying condition. If you take Humira or Remicade or Cimzia, and you are in remission, when I say remission, it means your blood tests are normal, your CAT scan is normal, and I put a scope inside of you, and it's completely normal. For 4 years, not 1 year, not 4 months, 4 years later, and we stop it. What percentage flare up? First of all, I'm just going to tell you that the likelihood of you getting there is probably 20%. Probably 20% of patients overall will get to that point. And it's a very depressing thing. But probably 20% of patients overall, 4 years out, will still be on Humira or Remicade and be in complete remission. Probably half of them, or less, when they stop it, will stay in remission. Not good. So what can we do? We can keep beating ourselves in the head, or we can do something different. What can we do different? We can try to do something ourselves. Go on a diet. Change what you're putting in your body. See if you change what you're putting in your body, alters your microbiome, alters your immune system, to now make this fight that's going on between the two of them stop. And maybe we can use, and I do this with patients, and my patients know this, maybe we can do this and we can do something to the person, to the patient, where their body is no longer attacking itself, where it's no longer promoting inflammation. So how long do I have to be on the diet? So I don't know if you have to eat asparagus and squash every day, but I know you can't eat donuts. So I think you have to be strict on the diet. And I'm not at the diet, I don't know what the diet is. I mean, I know what the diet is, but I'm not gonna, you have to be strict on the diet for at least a couple of years, get your immune system to change, and then be able to add in foods one at a time and see what happens. You also have to exercise. You also have to reduce your stress. You have to do all of those things to make your body heal itself. But if you keep eating garbage, you will not get better. You cannot eat like that. You can't drink soda. You can't have Danishes. You can't eat these things that weren't meant to be inside of you. You take people on diets, you put people who have eczema on a diet, all of a sudden the eczema goes away. You take people with psoriasis, the psoriasis goes away. You take people with celiac, the celiac goes away. We know that if celiac patients go on a gluten-free diet, the intestines get so much stronger. They don't allow the bacteria to penetrate the wall of the intestine. So why can't it work for inflammatory bowel disease? It certainly can. So what's with the diet? Well, one of the unique things about the community is that you're used to being on a diet. You're used to following certain rules that tell you what you're allowed to eat and what you're not allowed to eat. So for the Hasidic and Orthodox community, this is a big modification, but it's a modification that you're willing to do. It just takes a little extra energy. It takes more focus. It takes a lot of inner strength to say, I'm not going to eat that. Even though for that minute, it seems like it tastes so good or it looks so good, I'm not going to do it because the ramifications are that it's going to affect my health. And all I ever have to do when my patients ask me is I say, remember what you felt like before you were on the diet. However, anybody with one of these conditions needs to be followed by a doctor. They need to be followed preferably by somebody who deals with Crohn's disease and ulcerative colitis, because we need to know, not only do you tell me that you're feeling well, but that you are well. And that's, what's important. I don't think I'm going to talk about medication anymore. I think I'm going to stop there because I think there's going to be a lot of questions.